Well, welcome. My name is John Pandolfino. I'm the current president of the American Neurogastroenterology and Motility Society. And it's really my pleasure to invite you tonight and welcome you to our ANMS virtual webinar. Before we get started, I have a few specific announcements that I want to make. One is to mark your calendar for August 11th to the 13th for 2023 at the Fairmont Austin for our yearly scientific meeting, or our biannual scientific meeting. Should be a lot of fun. We've never been to Texas before, and we're going to try Austin. Also want to remind everyone that we're still open for the ANMS grant opportunities. Deadlines for the Discovery Grants are October 14th, 2022, and our new Transition Award also October 14th, 2022. I also want to thank Neurogastrics for their support for tonight's webinar. Gastroparesis is a very important topic and a very popular topic, and we have a great attendance tonight. So it's now I'm going to hand over the webinar to Linda Nguyen. Dr. Linda Nguyen is a good friend and really a spectacular clinician and researcher in gastroparesis. She's currently a clinical professor of medicine at Stanford University and the clinic chief in the Digestive Health Center. As I mentioned, her research interests really focus around everything GI motility, but she focuses primarily in the gut-brain interaction with an emphasis on functional dyspepsia, chronic abdominal pain, and as I said, gastroparesis. The other thing to know about Linda is that she's very passionate about professional development and physician wellness, and is also spearheading a lot of our work on diversity, inclusion, and equity. So without further delay, I'm going to hand this over to Dr. Linda Nguyen.
Great. Thank you, Dr. Pandolfino, and welcome to August is Gastroparesis Awareness Month. So this is a great session to kind of close out Gastroparesis Awareness Month. As John mentioned, this is a topic that is near and dear to my heart. And, you know, after being in this field for a while, the question that I keep coming across is, why can't we fix gastroparesis? And I'm looking forward to hearing from our speakers today. And I will present, I'll introduce both and then have them jump in one after another. And Dr. Brian Lacy, who will kick off the session, is a consultant and professor of medicine at the Mayo Clinic in Jacksonville, so Mayo Beach. He doesn't really need an introduction. He's published over 200 peer review articles, book chapters, co-editor of the American Journal of Gastroenterology, former editor-in-chief of the Clinical Translational Gastroenterology, co-chair of the Rome Committee. I mean, on and on. Brian really does not need introduction. And then we've got Dr. Katja Kovacic, who's associate professor of pediatrics and director of pediatric GI motility and cyclic vomiting syndrome. Katja also does not require any introduction. Her research focuses on the brain-gut disorders, and especially in children in functional nausea, gastric motor disorders. One of my favorite topics is non-invasive neuromodulation, and she'll be talking to us about how to treat gastroparesis in children and are the current guidelines appropriate. So Dr. Lacy, if you could kick us off with gastroparesis drug trials, why have they failed?
Okay, wonderful. What a delight to be here. It's a real honor to be here, and thank you for asking me to talk about a favorite topic of mine. And for those of you listening in today or listening in later, I want you to know that I'm actually an optimist, and I really believe that we can provide a lot of benefits and care to our patients, but I think it's important to look at this field very critically and try to answer the question. There's been so much research in this area over the last 30 to 40 years, but we haven't seemed to accomplish much. And so my topic tonight is gastroparesis drug trials. Why have they failed? And I believe that everybody can see my screen, and I'm going to look for a comment on that. I'm going to just jump on in now. And then bear with me for 1 second, please. Maybe you can't see my screen. Oh, okay, there we go. So our objective tonight is to review data from clinical trials to understand why medication trials for gastroparesis have not been successful. And it's important to understand that we're all using the same language. So gastroparesis is defined as, I'm sure everybody on the phone call tonight and webinar knows, it's a syndrome of delayed gastric emptying in the absence of mechanical obstruction and cardinal symptoms of early satiety, postprandial fullness, nausea, vomiting, bloating, and upper abdominal pain. And remember that paresis comes from the Greek term meaning weakness of movement. And we could have a discussion at some point about whether or not gastroparesis is actually the best term we should be using for this disorder, because most patients do not have a paralyzed stomach. This disorder has a huge impact on patients. We recognize that about 268 out of 100,000 US adults have gastroparesis, and that may mean up to 1 to 2% of US adults, depending on which survey study you read. We know that more women than men have this disorder. It's typically a little bit of a disorder for older patients in middle age, meaning 58 years, with a mean age of onset of 34 years. And this is from a very nice recent epidemiologic study published from Mayo Clinic, Rochester. We recognize that things have shifted a little bit, that most patients with gastroparesis are diabetic, and that means about 5% of type 1 patients. The second most common reason to have gastroparesis is after surgery, the post-surgical gastroparesis patient, and then drug-induced, and that's typically opioids. Idiopathic gastroparesis, in contrast to survey studies published 20 and 15 years ago, are now less common. We know that this has a significant impact on patients' quality of life, on par with those with mild to moderate depression. And we know from a number of different economic survey studies, this has a huge impact on our healthcare system. So if we ask ourselves, why have most gastroparesis studies failed? And I'm going to go through some of those in just a minute. I think there are a couple of key reasons. We have to ask ourselves, did the study subjects truly have gastroparesis? And I'm going to discuss the overlap of gastroparesis with functional dyspepsia. Were the subjects too heterogeneous? Was the sample size adequate? Was the study design appropriate? And was the study duration appropriate as well? And did the mechanism of action for the medication being studied make sense? And was the primary endpoint correct? So let's try to answer those questions. And as a part of the question about study subjects truly having gastroparesis, we have to ask, was the gastric emptying scan, or was the scan designed to measure stomach emptying, performed correctly? And did they have another diagnosis? So performing a gastric emptying scan should be easy, but it's critical that they be done correctly. And this is really a critical kind of therapeutic and diagnostic branch point. And the reason being is we need to properly identify those patients with delayed gastric emptying, because normal gastric emptying in patients with dyspepsia, those patients may have similar symptoms. And actually, some patients who have rapid stomach emptying may have symptoms nearly identical to those with delayed gastric emptying. And of course, if you have somebody with rapid gastric emptying, treating them as if they have gastroparesis could worsen their symptoms. In addition, and this requires another full hour of discussion, which we won't go through tonight, is that the extent of delay in gastric emptying may not reliably predict underlying pathophysiology. And I'm sure all of you who are listening in tonight have patients with a mild delay in gastric emptying, but very significant symptoms. And sometimes patients with a very significant delay in gastric emptying, but almost no symptoms, maybe just reflux. As well, it's, although controversial, and we could debate this, there's generally poor correlation between symptoms and gastric emptying time, as I've kind of mentioned. And we know the extent of delay in gastric emptying does not reliably predict response to therapy. Go back in time and think about ABT 229, a very potent gastrokinetic, could normalize gastric emptying, but did not improve symptoms, and similarly metemcenol as well. In terms of gastric emptying, there are a couple of points to be made. One is They have to be performed correctly. And we recently performed a survey study of over 800 institutions in the United States performing gastric emptying scans. And shockingly is not too strong a word here, only 5% performed all 4 key parameters correctly. I'll show you a slide on that in just a second. In addition, there's a nice smaller study from Mayo Clinic Rochester showing that there may be a value in repeating a test, in part because things can change over time, but in addition because oftentimes the initial study was not done correctly. So this is a slide indicating some of these 4 key quality indicators, and the compliant group is shown in dark black, that only about 58% actually do the gastric emptying scan for the appropriate period of time, which is 4 hours, not 90 minutes or 120 minutes. Interestingly, only 16% checked a blood sugar test prior to the test. That's absolutely critical. Only a third properly withheld opioids, and really doing a gastric emptying scan on for a patient on opioids is really, to me, of very low value, minimal value at all. And they oftentimes did not ask about properly withholding other medications, high-dose tricyclic antidepressants as an example, or GLP-1 agonists. So we can do better. And so when we think about some of these trials, we have to think about other possibilities for the true diagnosis as opposed to gastroparesis. And were patients with other diagnosis inappropriately included in these studies, and the most common cause or the most common reason would be functional dyspepsia. So as an example, let's look at the aprepitant study published in 2018 in a very high impact journal, Gastroenterology. Aprepitant, as most everybody knows, is an NK1 receptor antagonist and may improve symptoms of nausea in some people. This looked like a well-designed study, 8 centers, randomized, double-blind, placebo-controlled, with a reasonable sample size of 126 patients. But importantly, for a study that was designed to discuss a medication for gastroparesis, only 57% of the patients had documented delayed gastric emptying, a major flaw to this study. And we've learned that there's a significant overlap between functional dyspepsia and gastroparesis. This has been talked about for years. Editorials and studies have been written about this since about 2012. But coming from the NIH Gastroparesis Consortium, a group of researchers focusing on gastroparesis, they identified 720 patients with gastroparesis, and we're looking at those with functional dyspepsia. And what they found in this 48-week study, that over the course of time, about 40% of patients initially thought to have gastroparesis were actually eventually reclassified as having functional dyspepsia. And similarly, nearly 40% of patients initially identified as having functional dyspepsia were reclassified as having gastroparesis. So the key teaching point here is, do not consider functional dyspepsia and gastroparesis as completely distinct disorders. Think of them as a continuum that many patients with FD or gastroparesis, excuse me, little gap here, something changed. Many patients, I apologize, something happened to my screen. Many patients have a mild delay in gastric emptying. Many patients may also, about 7% may have rapid emptying. These are the FD patients. But certainly on the far right-hand side of the screen, those patients with very delayed gastric emptying would meet our definition of gastroparesis. So think about who was enrolled in these studies. Were subjects too heterogeneous? And we know that the pathophysiology of gastroparesis is very complicated. It would be kind of uninformed to believe that a single medication could take care of all of these symptoms: fullness, early satiety, bloating, nausea, vomiting, even weight loss. And I would challenge everybody in the audience tonight, post-surgical gastroparesis is completely different than idiopathic gastroparesis. This is a complication of surgery. It's very different than diabetic gastroparesis and certainly different than idiopathic gastroparesis. And many studies included opioid-induced gastroparesis, but that's a medication side effect. Again, the pathophysiology is completely different. And some of the pathophysiologic mechanisms are illustrated on this slide here. Let's also now look at the question of sample size, and was sample size adequate in these studies? I want to highlight some of the key studies for metoclopramide, which led to the eventual approval of metoclopramide. By the way, metoclopramide was approved by the FDA in 1979. That's the last time, 1979, 43 years ago, a drug was approved for gastroparesis. And look at the sample size, 10 patients with diabetic gastroparesis, 5 patients with diabetic gastroparesis, 13 patients with diabetes, 13, 1, and 10. Very small sample size, completely different than how studies are performed now. Similarly, if we look at domperidone, we see some studies with 3, 6, 12, 13 patients, incredibly underpowered. What about study design? Was the study design appropriate? And many studies were open label. Some studies were crossover and inadequately powered. Many studies have been retrospective, and many studies did not identify a minimum symptom level. So there may have been a floor effect. And again, if we look at domperidone and we look at the far left-hand side, open label study, retrospective, open label, crossover, crossover, crossover. So study design for many of these was not appropriate. What about study duration? So when we think about FDA guidelines now for something like IBS as an example, the minimum study treatment is 12 weeks and ideally 26 weeks. But many of the older metoclopramide studies were 3 to 4 weeks. The domperidone studies on average were 4 weeks. But newer studies are actually not much better. The aprepitant study was 4 weeks. The tradipitant study was 4 weeks. And the prucalopride study published in the American Journal of Gastroenterology was longer at 8 weeks, but it was a crossover study. So we really should be thinking about 8 weeks at minimum, and 12 weeks would be better. And so this looks at the aprepitant study, again, a 4-week study. Maybe that's why the primary endpoint failed. Did the mechanism of action make sense? We should ask this. Think about erythromycin, frequently used by providers to improve gastric emptying, but accelerating gastric emptying may not improve symptoms. We know that very well from the ABT 229 studies. What about relomorelin? Those trials have not stopped. There was some preliminary interest and some good results in earlier studies, but similar issues, relomorelin, a ghrelin agonist accelerates gastric emptying, but may not improve the multiple symptoms of gastroparesis. And similarly, aprepitant, an NK1 receptor antagonist, it plays a role in the development of nausea, but it's only a small role in this very complex pathophysiologic process of nausea and vomiting. And of course, what about the primary endpoint? Was that appropriate? Well, many older studies focused on evaluating changes in gastric emptying. But we now know that accelerating gastric emptying may not improve symptoms, and the FDA now counsels all research studies and researchers against using gastric emptying as the key endpoint. We should be focusing on symptoms. In contrast, this recent study, tradipitant, published in Gastroenterology last year in 2021, although it was a 4-week study, did not use gastric emptying as a primary endpoint. It focused on symptom improvement. And of course, that makes much more sense because that's why patients come to you. They want symptoms improved. So in summary, gastroparesis really is a challenging field and remains so for a number of different reasons. Looking back at the literature published over the last 30 years, most studies have significant study design issues. Many studies enrolled patients who probably were not appropriate. We need to carefully distinguish gastroparesis from functional dyspepsia, but also subtypes of gastroparesis. We cannot lump them together. We need to make sure that studies are longer, and we need to focus on symptom improvement as the key endpoint and not a surrogate marker such as gastric emptying. I'm going to stop by there, and I know we'll have time for questions later, so thank you very much.
Great, thank you, Dr. Lacy. So up next, we'll have Dr. Kovacic load up her slides. Actually, Brian, if you could stop sharing your screen. And I forgot to mention, please put questions for both Drs. Lacy and Kovacic into the Q&A, and we will get to those after the session.
All right, thank you for that introduction. Linda, it's a pleasure to be here today. I'm going to share my screen, and I'm going to talk about how to treat gastroparesis in children and are the current ACG guidelines appropriate. So I will review some snapshots of the adult 2022 ACG gastroparesis guideline and how they may be or may not be applicable to pediatrics. I have no financial disclosures. So the first guideline touches on diabetic gastroparesis, and we don't have that problem in children almost at all. So we're just not gonna be talking about that. The second one is where I have a lot of interest, and we need to have some understanding and discussions of what's happening. So gastric emptying scintigraphy is the standard test for the evaluation of adult gastroparesis, and the suggested method of testing includes appraising the emptying of a solid meal over a duration of at least 3 hours. And there's moderate level of evidence and a strong recommendation in adults. So what about pediatrics? Well, the issue is that we have no normative ranges for the gastric emptying scintigraphy nuclear scan in children. This is very problematic. It's a major dilemma for us because without being able to diagnose it properly, our treatments suffer, and we are sort of in the blind and darkness of what to do with these patients. We still continue to extrapolate a lot from adult data, but without having pediatric norms, this is very problematic and begs the question, should we even perform this test in children? There are no norms, and there maybe never will be because this test involves radiation. So what studies do we have? Well, this is essentially 3 out of 4 that there is on gastric emptying scintigraphy in kids, touching on some of this subject. This retrospective study from 2013 of 71 children who are presumed to have gastroparesis showed that extending the test to 4 hours increases the yield without increasing the cost, and that's a finding that's as the ACG guidelines recommend has been proven in adults as well. So the longer duration of the test seems to be better, but it was retrospective and used adult norms. And then we have a prospective study that attempted to establish some cutoff values for children and try to set some normative ranges, but it's a small study of only 30 healthy controls, and there's a different meal composition and body position during this test. It was a vegetarian meal, so how can we even know what this means? And obviously we need a lot more data than 30 healthy controls in children. So that's really the only study using gastric emptying scintigraphy in children to try to establish ranges. And there's a retrospective larger study that showed that the gastric emptying was affected by age and body surface area, which is not surprising. But the problem with one of these studies, including young children down to age 4 and up to 18, and the same meal size was provided to all ages. This is very problematic in children. How can we put a large adult size meal in a 4-year-old and think that we are going to extrapolate scientific findings from this? So here are some of the flaws, and that we really do have a data problem in pediatric gastroparesis field. So another ACG guidelines is that radio opaque marker testing is not suggested for diagnosis of gastroparesis. There's very low evidence for this, and I just want to quickly point that out, that we have no pediatric norms for that either, so probably not something we should be doing. What about the spirulina breath test? So this is an old test put to new use again, and this is per the guidelines is a reliable test for gastroparesis in adults. In fact, is showing some good agreement with nuclear scintigraphy in adults, and based on some fairly rigorous data, showing 89% sensitivity if we can trust that gastric emptying scintigraphy as the standard of care. And now, of course, this is in adults. It's been FDA approved in adults. And the exciting part of this test is that it involves no radiation. So we have actually performed this in children at our center. And there's been some other various gastric emptying breath tests used in children as well, but unfortunately, often using different test meals, and we can't really compare the different studies to each other. But this spirulina gastric emptying breath test, or GEBT, is a nice non-invasive alternative where carbon-13 is ingested, and the rate limiting step for when it's picked up in the breath is the gastric emptying. And it's a neat and non-invasive test where we create these curves. So the dashed line here is the cutoff for adults norm. So if you fall under that during these 4-hour time points, you have delayed gastric emptying. What about children? Do we have any cutoffs? We don't have strict cutoffs, but we have performed a lot of this testing at our center in our prospective trials, and we do see this test performing interestingly, showing a broad range of low value. So this patient is a patient with suspected gastroparesis, and in fact had a normal nuclear gastric emptying scan at 4 hours. And look at this test is also normalizing and above that cutoff at 4 hours, but looks horribly abnormal. So I think is in the hours before. We don't know what this means, so what time points this test is abnormal, what time points to evaluate, but it's certainly giving a nice comprehensive picture of the gastric emptying over those 4 hours. So we need more data. We have attempted to do this in 100 kids, and we need a greater amount of healthy control data to really establish pediatric cutoff. But this study did show the impact of gender, body, and pubertal development. So we found that there was pubertal differences, and specifically prepubertal children had faster gastric emptying, as seen here by the light gray. They had higher excretion rates, and this is an interesting finding, especially applicable to pediatrics where we have pre and peripubertal and postpubertal children. We are finding more evidence that we can't simply take the adult cutoff value and comprehensively use them in clinical care. So another interesting note from this healthy control study is that females were found to have a longer T half-life and therefore slower gastric emptying, which has been shown in multiple adult trials already. And you can see that the area under the curve here is lower in females, and therefore they're slower. Multivariable analysis in this study again showed that prepubertal children have high excretion rates, faster emptying. Females have slower gastric emptying, and slower gastric emptying correlated with higher body surface area, also shown in adults before. So slower gastric emptying in females and larger individuals. So I just wanted to point that out, that I hope that we can get more data using this test, because then we might have a pediatric non-test without radiation where we can create some cutoff values. Other groups, this is Texas Children's groups, have taken about 100 kids with dyspeptic features where half of them had gastroparesis, and also found that girls had worse symptoms. So again, pointing to some gender differences. And nausea continues in pediatrics to be one of the key findings in these patients that correlate with gastric retention, but we don't have a lot of data. But again, symptom severity has been often shown in adults. This study found that there's very little differences in the symptom severity in those with normal versus delayed gastric emptying. Just another point to show that what does this mean? Where is the cutoff for abnormal and versus normal? What does it mean in terms of severity of symptoms? Well, we just in the blind because we just don't have good cutoffs. And obviously this study used scintigraphy. So wireless motility capsule testing may be an alternative to scintigraphy per the ACG guidelines. In kids, we have simply 2 studies. This is one of them of 57 children, and there was no association between the wireless motility capsules and symptoms. And also, it really only had fair agreement with scintigraphy, and there's no pediatric established norms. So while this could be somewhat exciting of a novel tool, we really don't have the data to support its use. Reimbursement for this and using it in clinical care is problematic. But and another test that would be nice if we had some norms. So what about the actual management? And small particle diet is part of the ACG guidelines as a recommendation, which is we frequently do in pediatrics as well. So there's no harms to the dietary modification, except that we are seeing a larger number of patients and pediatric patients with restricting eating habits and ARFID. But small particle size diet, part of the management, part of the ACG guidelines, and that's based on a randomized control trial. What about the drugs? So there are a lot of drugs to be considered, not a whole lot that have evidence-based, and not a whole lot that are safe in children. So metoclopramide, per the guidelines, is supposed to be reserved for those with refractory symptoms. There is a lot of hesitancy in pediatrics to use this drug, given the neurological potential long-term side effects. Even though the frequency of those have been shown to be very low, this is a huge concern when you deal with children. Of course, there's a new intranasal form that might be a nice option to consider, especially for children, but we have no data. Domperidone suggested to be considered where it's approved and available, which is not in the US. 5-HT4 agonists for refractory symptoms. So the ACG guidelines suggest we use them in refractory patients. And there's, I'll show you some data on prucalopride in particular is an exciting new agent that is coming to pediatrics. So there's some newer drugs that we can consider. The standard antiemetics is recommended only for symptom control, and the guidelines point out that they do not improve gastric emptying. So again, children, there's no data on these, but I think considering the use of aprepitant, for example, which is a novel, quite effective antiemetic children has data in cyclic vomiting syndrome, but not in gastroparesis. Some of these are really just band-aid, but in combination with other perhaps non-invasive management options, these certainly can be considered. So I want to point out that the guidelines recommend against the use of central neuromodulators. There's randomized controlled trial using nortriptyline in adults that did not show efficacy in gastroparesis. And we've heard from Dr. Lacy that there are certainly a lot of flaws and difficulties with the design of clinical trials, and that we need better clinical trials. But if we trust what's out there, then central neuromodulators are not recommended. And we continue to use drugs like the tricyclic antidepressants quite heavily also in pediatrics, and we need to start to acknowledge that how they work and what types of side effects, including long-term issues with dementia, that these are potentially very risky agents and do have a black box warning in children. For this, there's moderate evidence and strong recommendations. So I would really take that to pediatrics, where we also do not have evidence. We have one randomized trial, and we have some more recently, but particularly one that showed no effects over placebo for functional abdominal pain. We have no trials in gastroparesis. So I just want to point out the study on prucalopride for children with upper gastrointestinal symptoms. This study was retrospective, but from our Boston Harvard group of colleagues, they took patients with nausea, feeding difficulties, and reflux, and probably a subset with gastroparesis, but interestingly, 65% improvement was documented at long-term follow-up with this use of prucalopride, which is somewhat exciting, but we really need prospective randomized trials in children. Those patients who improved had a higher use of ventral tubes, pulmonary neurologic comorbidity, so they appears to be effective in quite refractory patients, which is perhaps some good news. But typically those agents have not been used until you failed several drugs. So these clinical trials or studies tend to be a little bit biased towards those more complex patients. So here's a management algorithm that you can find in the ACG adult guidelines. And I guess point out that it's quite sad that we fit everything on one page because we have so little data and so few treatments, and the drugs kind of hang out here, pharmacological and treatment options to be considered, but as I just shown you, very little evidence for them. We should really consider the dietary modification and then nutritional support in all these patients. And then we get a little bit into the non-pharmacological options here at the bottom. And what about some alternative therapies? Well, the ACG guidelines point out that there's very low evidence for the use of acupuncture, Reconchido, and STW5, which is Ibergast. So unfortunately, no data to support it, but it's nice that they're including it, because we have in pediatrics, for the first time, we're a little bit ahead of the game in pediatrics with the use of auricular neurostimulation, and data that's emerging is quite exciting. We've shown that it's effective for adolescent functional abdominal pain, which is not gastroparesis, but this recent study showed some efficacy in functional dyspepsia. Again, was not a placebo trial, but suggested that these patients have improved drinking capacity with the use of auricular neurostimulation to the outer ear in a 4-week course. And that's exciting for the potential of this treating patients with gastroparesis, although we need to acknowledge there's many different mechanisms of gastroparesis. And if this perhaps affect afferent vagal signaling, there is a mechanism there for influencing stomach emptying. But we really need data on this emerging therapies for gastroparesis. What about Botox? Well, this is not recommended per the guidelines in adults based on randomized trials. Moderate evidence, strong recommendation. Does this apply to pediatrics? Well, we have such few drug options, we have such few treatments that it's quite heavily done in pediatrics, at least at the larger centers, and is often combined with pyloric dilation. This is a French study showing, just a small study, but showing that 76% success rate. Half of them got the Botox in combination with pyloric dilation. Unfortunately, 57% recurrence rate, which is a common issue with these interventions. But again, in kids where we really are scared of using a lot of the drugs that are available, we do want to maybe consider this, and we actually have a little bit of data suggest this was done by our Cincinnati colleagues. The study compared Botox and pyloric dilation in 76 cases versus 76 controls who got standard medical therapy, and they also document a good response rate, 76% versus about half in controls, and also more longer lasting response. And I believe that some center is now doing a prospective trial with this invention in pediatrics, which is really what we need. But for us, it's not entirely helpful to have this recommendation, especially dealing with insurance companies. And we like to use it when we can, and there are patients and children who benefit. So that's something where we may differ a little bit. Gastric electrical stimulation is recommended as to be used, considered as a humanitarian device. And we do have pediatric centers working on this and doing so wonderfully and showing some wonderful data. This is a 10-year experience coming from Nationwide, showing quite encouraging data using the gastric pacemaker in children. So in summary, there are important differences between children and adults in the diagnostic capacity for gastroparesis, which is so important to acknowledge and understand because that influences our treatments. Normative pediatric data is hugely desperately needed for a test for gastroparesis, let's put it that way. There's very scant data on management options, just like in adults and even less in children. Larger control trials are really desperately needed. And thank you, ANMS, for allowing me to have this lecture.
Great, thank you both to Drs. Lacy and Kovacic. And if I can have both of you join me on the panel, I've got some questions here. And kind of one question here from Dr. Parkman that kind of piggybacks to the question that I have. And this one's for Dr. Lacy on clinical trial design. The first question is, what's an appropriate duration for study in gastroparesis? And the second part, which is kind of the question that I have, is that oftentimes, the phase 3 trials, we have a placebo control arm, where we ask patients with moderate to severe symptoms to then stop all concomitant medications and stay on, and do this for 12 weeks. So what are your thoughts on, first, the optimal duration, and then, second, the trial design where we're asking patients who are getting placebo to not take anything for their symptoms?
Yeah, two great questions. So the first question for Dr. Parkman, and for those of you on the webinar tonight, Dr. Parkman for 30 years has contributed so many amazing studies to the field of gastroparesis. So thank you, Henry. So Henry, you may have read our mind. So we have spent the month of July and August looking at 231 studies published for gastroparesis, and we've waded through the literature, and we'll present this later this fall. And what we found is that we're trying to identify the placebo response, but we looked at all these studies performed in gastroparesis. And what we found is that for under 8 weeks of duration, the placebo response is so high, it really negates any possible therapeutic gain. So that's why I mentioned earlier, at least 8 weeks in duration, 9 weeks or more, and probably 12 weeks, but so few studies have been performed for 12 weeks, almost none, that we can't really confidently say that. So the answer is at least 8 weeks, but I think it should be 12 weeks. Linda, your point is really good, and this is really reflecting the real world experience, right? So we have these patients with multiple symptoms: fullness, early satiety, bloating, nausea, and vomiting. And we're telling them, you've got to come off everything and be miserable for the next 3 months. I mean, that's really not reasonable. And so one thought is that with studies in the future, should we allow patients to remain on a reasonable medication, right? If they're having some relief of medications, do we add on? And this is what we do in the real world all the time, right? So if somebody has gastroparesis and they have some response to domperidone, but they're not having complete relief, you don't say, well, stop it. Let's completely go to a scopolamine patch as an example, or a prepitant or tradipitant, whatever you think is the best choice for that patient. You would say, let's layer on drug B, and sometimes layer on drug C. Let's use, Phenergan at night as an example. Let's use granisetron patch as well. Let's use metoclopramide nasal spray. So the answer should be, moving forward, would you allow patients to maintain some simple level of drug therapy to have some control of their symptoms? And we can measure the additional therapeutic gain.
Right. I love that idea, especially as someone who tries to recruit for these 12-week trials. I'll start this next question for both Brian and Katja, but to kind of compare and contrast the pediatric and adult perspectives here. Brian, you mentioned kind of subtyping gastroparesis. And I know there were publications on kind of the predominant symptom, nausea, vomiting, pain predominance in terms of, enrolling in clinical trials. Do you see this as a pathway for the future in terms of targeting the symptoms? And then for Katja, do you subtype in the pediatric world?
Linda, I think there are two layers to your question. So I'm going to go back and just repeat something I said earlier. All future trials should very carefully subtype what is presumed to be the underlying pathophysiology, and we can't group patients together anymore. To include post-surgical patients is, in my mind, just craziness. That's a complication. It's not a disease. And we should certainly separate out diabetic patients, and probably type 1 versus type 2, and idiopathic patients, and get rid of the opioid-induced group. So that's the first layer. So moving forward, we need very careful attention paid to what the patient enrollment is. Your point is, should we then subtype? And I think the answer is yes, because many of these patients are pain predominant. That's probably a different pathophysiology than somebody who's nausea predominant or vomiting predominant, or don't forget bloating, right? William Hassler, who was at Michigan for many years, now at Mayo, Arizona, showed that bloating is incredibly prevalent in these patients. So why isn't this like IBS? Right? We have IBS with constipation predominance or diarrhea predominance, and maybe moving forward, that'd be another way. It does make recruitment trickier though, right? We have trouble recruiting patients, but maybe that would shed some light, and maybe that would explain why many medications don't seem to improve symptoms.
100% agree, because we are in pediatrics as well. We're dealing with a lot of different populations. We don't have the diabetic, and we don't have as much post-surgical perhaps, and opioid induced, but subtyping with especially the pain versus nausea, vomiting as a predominant symptom, there's something there, because we repeatedly see the gastric pacemaker trials working quite efficiently for the nausea and vomiting patients, but not for the pain. So what is happening there? And again, as you touched on, there's so many symptoms going on here. And also subtyping for comorbidities. Look at the many patients. What is idiopathic gastroparesis? Do they have dysautonomia? Because in pediatrics, we certainly see tons of that, and probably do in adults as well. Are those idiopathic gastroparesis? What are all the comorbidities telling us that's going on with these patients? So I think we're probably lacking in phenotyping these comorbidities better, and it's muddy. I'm trying to do this in a large prospective trial, and it's going to be very muddy, but sometimes they can tell some stories about these patients, and there's so many mechanisms of gastroparesis, which is what is really tricky.
Okay. To further muddy the water, there was a question about the gastric emptying test, especially the scintigraphy or the spirulina breath test. What if you have delay at 1, 2, and 3 hours, but they catch up in normal at 4 hours? What do you make of this? Do you call it gastroparesis? Do you call it CUNV, FD, other?
Yeah, what a great question, and maybe I'll put my foot in my mouth first, and then Katja, you can help clean this up. So if we follow the guidelines, so I like the question for a number of reasons. One is we have to do 4-hour scans. We have to do 4-hour scans. Florida is notorious for doing 90 and 120-minute scans, and they're essentially worthless because most everybody on the call knows if you finish tonight and you go have supper, in the next hour, all that food is in your fundus, right? And then it slowly starts to move through the body. And so everybody's going to be delayed at 60 and 90 and almost 120 minutes. But if we follow the guidelines, we know that for gastric emptying, normal gastric physiology, the majority of emptying starts to occur at 2 hours and really during 3 hours and 4 hours. So I don't read much into some delay at 1, 2, and 3 hours. I look at 4 hours, and I don't really look at 10% remaining. I look at about 20 or 25% remaining. Most of the people with 11, 12, 13% remaining in 4 hours, that's your dyspeptic patient. That's not your gastroparesis patient. I want to see a significant delay at 4 hours.
Yeah, I think those are good points. I think this could differ a little bit in kids, and sadly, we don't know. But everybody knows that a baby empties everything out much faster than an adult. And looking at our data that I just showed you in prepubertal children, that we have established that they've emptied faster from a pretty decent cohort of healthy controls. We may be looking at very different norms here. So in kids, it might be that 2 or 3 hours, 3 hours perhaps could be sufficient. Although we did have that one study showing that 4 hours was also better in kids versus 2. But again, what are we comparing it to? What's our standard of norm here? So I have a sense that it could be a little bit more important with the earlier hours of emptying in children for the young kids that are prepubertal.
And so to further that question, for the kids and adults who can't tolerate solid meal and you have to do a liquid gastric emptying, how do you interpret that?
So we know that there's a lag phase of solid through from emptying from the stomach, and liquid empties very differently and sort of exponentially immediately goes through the stomach.
Katja, you cut out for a little bit. What I think I heard was that it's hard to interpret and you find the liquid emptying useless.
Yes, I'm sorry, my internet is a little unstable. I was talking about the lag phase of the solid meal versus the non-lag of a liquid meal and the caloric content changes. I think in children, this is an area where you wouldn't use it because we just don't have norms, and it empties so differently with liquids.
Brian, your take on the liquid?
Similarly, I think liquid emptying scans should not be performed in adults. They are basically uninterpretable. We don't have any norms. They're really of no value. If you remember your gastric physiology, remember gastric liquids basically empty by gravity. If you go out for a run or you go to the gym and you drink that quart of Gatorade, you're going to walk for a second, you're going to hear that little succussion splash, right? But liquids, 50% empty within 7 to 8 minutes by gravity. And liquid scans should only be performed maybe for if you're concerned about dumping syndrome. That's very old data, but I don't recommend them at all. They should not be used, basically worthless.
Okay. And then a couple kind of controversial questions about the FD and GP overlap. I'll start with Katja on this one. So in kids, like, how do you make the differentiation between FD and GP? Perhaps, I think Katja may be frozen. So Brian, how about you?
Yeah, well, it is Wisconsin, and she's very cold in Wisconsin right now. So this is a great teaching point for everybody. We used to think that you either had FD or gastroparesis, completely separate disorders. We now recognize there's a huge amount of overlap. As a matter of fact, we recently did a study that should be published later this fall. We looked at 400 consecutive patients referred for gastroparesis. What did we find? Only 20% actually had gastroparesis. The vast majority had functional dyspepsia because the symptoms are all so similar, right? Fullness, pain, pressure, discomfort, nausea, bloating, early satiety. So I do use a standardized egg beater 4-hour solid phase scan to distinguish those patients. If patients have a normal scan or rapid emptying, 7% will. They have functional dyspepsia. If they have a very mild delay, they're pain predominant, fullness, that's functional dyspepsia. I mean 11, 12% remaining, but that's certainly that patient with 25% remaining at 4 hours, 30%. And I want to hear vomiting. So patients who come in, fullness, early satiety, and they have a mild delay in gastric emptying, that's your functional dyspepsia patient. You really want to hear vomiting for these patients. But I think it's really critical because that is a triage point. So the gastric emptying scan, some people challenge, is it useful in this day and age? Absolutely, because you want to make sure you don't have somebody with rapid emptying, and you want to triage the FD patient who may do better with neuromodulators than the gastroparesis patient who may not do as well with neuromodulators, as one example.
So there was a question regarding constipation, or how much does constipation play a role in the symptoms of gastroparesis as well as the delay in gastric emptying?
Yeah, what a great question. So whoever asked that question, you obviously are taking great care of your patients and you're taking a great history. So do ask about constipation, because oftentimes they coexist, but could they even be playing more of a role? And the answer is yes. So constipation, when somebody's constipated, there's a negative feedback loop that it sends signals from the colon back upstream to slow stomach emptying. And so for those patients, you want to treat their constipation, and that may improve some, but likely not all of their gastroparesis symptoms. Now, how do we really know that? So don't forget that great study that's probably about 30 years old now, where they took medical students. This is when we're allowed to do students with studies with medical students, right? Always a great patient recruitment. Take medical students, measure stomach emptying. They were all normal. Then what did they do? They made them all really constipated and remeasured stomach emptying. What happened? Gastric emptying slowed down. So for these patients, take that history, identify constipation, treat the constipation. There may be some improvement in gastric emptying, but it's probably not going to normalize.
Okay. And then another question is for those with pain predominant gastroparesis or functional dyspepsia, what's your go-to in terms of therapy?
So what a great question. So remember that about 98% of patients, and this is actually coming one of Henry Parkman's nice studies. I think the actual number is 89%, but about 89 to 90% of patients with gastroparesis have some pain or discomfort. It's a neuropathic process for many patients. And similarly, functional dyspepsia is defined by pain, discomfort, epigastric distress. So what agent should we use? Well, one thought would be, could we use a tricyclic? Unfortunately, that study, the Norrig study, published many years ago in JAMA, again by Henry Parkman, was a negative study that it did not, nortriptyline did not improve gastroparesis symptoms. But I wouldn't quite give up. So as an example, think about your diabetic gastroparesis patient. And some of those patients do respond to low-dose neuromodulators like a tricyclic antidepressant. Alternatively, could you use other anti-nociceptive agents? Could you use low-dose gabapentin? Could you use low-dose pregabalin? Absolutely. And probably these pain signals are different in different people. What about mirtazapine or Remeron? Can improve many upper symptoms. There is some concern that very high dose could further delay stomach emptying, but low dose may improve symptoms of nausea and fullness and distress, and also some mild anxiety. So don't forget that these neuromodulators, whether they're a visceral anti-nociceptive agent or a central, may improve symptoms, and don't be afraid to layer them on to your antiemetic regimen.
Katja, welcome back. What we've been talking about differentiating, FD from gastroparesis. So from a pediatric standpoint, how do you make that distinction? And then Brian was talking about treating pain predominant gastroparesis with neuromodulators. Is this something that you use in the pediatric group?
I started talking about the differentiating
differentiation of FD versus gastroparesis in pediatrics is exceedingly difficult, and probably even more so because we just don't even know what these FD patients are at all. We have no Baristat studies in children. We go by the symptoms, and they have very, very similar symptoms. So I don't know how to differentiate them. Perhaps clinically with somebody who have delayed emesis of delayed after eating of undigested food has more of a gastroparesis pattern. But in pediatrics, we have not a lot of instruments to distinguish them. I agree that neuromodulators is probably kind of our only option at this point for treating pain. Those other modalities don't seem very effective, such as neuromodulation. Perhaps auricular devices and non-invasive therapies certainly can work for pain. So I think that's encouraging, but in children, we really don't have other effective options. So I use neuromodulators as we can and as safe as we can keep them. We have to be very careful with tricyclics and the mood changes and suicidal ideation and the black box warning in kids.
Great, thank you. So another question goes back to the gastric emptying test. So lots of questions about testing. So if you have someone, it's delayed, you diagnose with gastroparesis, and Brian, you showed the consortium data that 40%-ish changed a year later. So now what do you call patients, these 40%? Do they still have gastroparesis? Do you change the diagnosis to functional dyspepsia? What happens to the diagnosis at this point, since the symptoms didn't really change?
Yes, so great question. So this provides or provokes a lot of discomfort in clinicians and oftentimes patients, right? Patients, as we know, become very wedded to a diagnosis, whatever that diagnosis is, really doesn't matter. And so do clinicians, but I think we need to take our blinders off and be a little bit more flexible. A great example is the overlap of chronic constipation and IBS with constipation. And we know that people move from group to group depending upon the intensity and the frequency of symptoms, such as pain. So it shouldn't strike us as unusual that people can move from functional dyspepsia to gastroparesis and back and forth based on the degree of delay in gastric emptying and based on symptoms. I think what we should do is, again, think about, I've proposed the term dyspepsia with or without delayed emptying. Nobody seemed to like that. That's okay. I'm not offended. But I think we think about just dyspeptic process and focus on the predominant symptom. Focus less on giving people a label. Focus on the symptom and what's most bothersome to the patient and address that.
Katja, what about you? I know gastric emptying is difficult in children. Do you see this flip-flop in kids?
Yeah, absolutely. And we, hormonal changes and that influence gastric emptying rates and the symptoms. We have the same, I think, variability in testing. Normal at some point, abnormal at another point. I also think that we have to step back from those labels. And I also want to point out that gastroparesis is a label that we know, but what about all the things that we don't know? We're looking at simply the emptying of food. What about the newer data on intragastric meal distribution, be it abnormal, or the, that we don't know as much about the accommodation or the blood flow through the stomach. This is simply one label that we know, and we may be looking in 10, 20 years at many different disease processes going on with the motor function of the stomach. So a better word might be there's motor dysfunction of the stomach or the dyspepsia. I agree. Call it dyspepsia. And yes, prokinetics is preferably used when you have an emptying delay. So that's how we change treatment. But aren't we testing all of these agents and therapies and sort of all of them at some point anyways? So I think get away from the labels is best.
Great. Thank you. Lots of great questions, and we're not going to have time to answer all these questions. We will transition these questions over to Doc Matters, where they'll be answered there. And then if you don't have access to Doc Matters, we'll try to get the responses to you via email. So one last question before we wrap up. What about the people who have symptoms with water, but not other liquids?
Oh, Lynn, so if patients report symptoms by drinking water,
Yes.
but not, so that's actually a question I ask many of my patients with upper symptoms. And at least the way I explain it and the way I believe, is that water is a pretty benign substance. And if you have symptoms drinking water, I think that's usually a signal of significant visceral hypersensitivity. Water should not cause distress. And that to me is a marker of visceral hypersensitivity, which can be seen certainly in functional dyspepsia, but also with gastroparesis. Many of these patients are extra sensitive.
Agreed.
Okay, well, thank you, Brian, Katja, for a wonderful discussion. I could probably keep you here for hours, but I will not, since it is in the evening on the East Coast. And thank you for all those joining. You will find this recording on the ANMS YouTube and the further discussion on Doc Matters. Have a good evening, everybody.